Okay, so the first topic today is basically small bowel obstruction. So first of all, make sure you open up a picture of ultrasound from Google or whatsoever along with you. I'm not opening up it here, so we are going to start it, but it would be highly appreciated if you can open it up, so it will be very easy for you to make up concepts. So now coming back to mechanical small bowel obstruction, it is basically common causes. So you need to know the common causes first. What are the common causes? This is basically extramural one. Extramural adhesions, hernia, and carcinoma. It doesn't mean that it cannot present with the Crohn disease, radiations, neoplasm, lymphoma, intussusception. It can present with it, but you need to remember the most important ones. What are the most important ones? Basically, more than 85% presents with the adhesions, incarcerated hernia, peritoneal carcinomatous. So at least, if you cannot remember these ones, that's what I said. Always remember the common ones. It is okay if you forget about uncommon ones, because obviously we are human, so we cannot remember everything. So at least remember the common ones. Okay. When Toronto Notes said this is common, like more than 85%, 95%, it means in Canada, these kind of cases present more often. So they are not going to go out of scope and ask you something which is very uncommon, right? So you need to know like the common ones. So extramural is more than 85%, which presents as adhesions, hernia, and peritoneal carcinomatous. And you shouldn't be stick with only adhesions. Adhesions can present with the previous surgeries, right? So you need to know, if you're reading those causes, what could be the cause of those causes as well. So you need to know the proper background of all the etiologies or causes. What are you reading? So if you are reading this adhesions, how can the adhesions be formed? So you need to know this as well. It might present you as a surgery and they don't give you the adhesions and give you a small bowel obstruction presentation, right? So you need to know that surgery causes adhesions causes obstruction. So, it comes in a circle or it comes in a cycle. So you need to know this. Then hernia, then peritoneal carcinomatosis. So this is important. Then increased risk of perforation with the dissentation. This is like the centimeters given. Important to know if the chronic or acute, because acute and chronic is something different and presentation is different as well. So you need to know which is acute and which is chronic. So this is given like if partial, then complete, 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 complete. So this is something you can, if you go through the ultrasound, you can see which one is partial, which one is complete. And I would highly recommend, if you can appreciate which one is partial, which one is complete, it will be really nice, because if you are going to write it down, it will be give you a very good presentation, right? If you can write down this is a complete one and this one is a partial one, so you can easily write down, and it will give you a very, like when you are writing down a CDM question, you will write down partial SBO or partial small bowel obstruction. It will be like examiner will think that this person knows or appreciates the partial one from the complete one, right? If you already write the small bowel obstruction, anybody can write that. But if you are writing partial or small, complete, it might give a good impact on that. So it is kind of that thing. Minimal intestinal obstruction with no evidence of obstruction, with a complete is basically with obstruction. So complete with a compromise. So you don't have to go all the way from the viable and everything, because the presentation will show you, yeah, this is something is presenting like that way. Okay. So patient with the no abdominal surgery history were like virgin abdomen. So it should have been surgery as soon as possible. It might present and then you go for laparotomy right away. So it might be a malignant obstruction. So on the basis of history and imaging, you can see that she never had any surgery, or he never had any surgery. So now we can do surgery as soon as possible, because it could cause. So if obstruction is coming and it's the chances of like a viable bowel, like the tissue is still preserved, what you can do is you can save it. But if it's not viable, you have to remove it. So it is depend on the basis of that, because non-viable tissue can easily perforate, and you have to save the patient from perforation. Perforation is like a third level complication which you have to preserve it, right? So when we are reading the treatment, I will let you know how you are going to tackle up the question. It is very important on the basis of small bowel obstruction, where you're going to write what kind of answer. So three main causes, these ones: adhesions, bulge, and cancer. Risk factor is basically previous surgery. As I told you, adhesions are linked with the surgery, and any abdominal wall. Maybe female is pregnant for more than 7 times, 8 times. So abdominal wall is weak, so having hernia. History of malignancy, poor radiations, IBD, and the foreign body ingestion. Then comes the clinical presentation. It might be colicky, periumbilical pain, nausea, vomiting, obstruction, passage, instability, inability to pass, flatter. So these kind of presentation, because if a person or patient has this obstruction, all those signs of obstruction will present. So you need to know if she's not passing any gas, either from not passing any flatus, having obstipation. So you need to remember what is constipation and what is obstipation. Constipation is like we already have a concept about. Obstipation is not even passing gas and not even passing stool. So all these things, nausea, vomiting, pain, tolerance to the oral diet. So you need to know on the presentation of that, if somebody is having chronic, what happens is she might have developed the tolerance to it. So she might not present, or he might not present in emergency. He might present in the clinic and you do some ultrasound. So you get to know, yeah, this is not a chronic one, or this is not an acute one. So on the basis of that, even the presentation, the ultrasound, you can find out what is going on. So most frequent vomitus suggests most established obstruction and passage of gases that continues for 6 to 12 hours after onset of the symptoms, suggests partial rather than the complete one. So this is something you can remember, how partial and different from the complete one. Inability to pass flatus is the most useful indicator. So this is all the causes. If you cannot remember all of them, like it's very nicely written here, shaving. So at least remember the top 3. I would suggest you to remember these ones, but let's suppose you if you make a concept, it will be very easy for you. But if still in a very low level, if you cannot remember it, at least do these ones. Okay. Then comes the sign. What happened is distension, hyperactive proceeding, bowel sounds, blotting, hypovolemia, hyperresonance. Then comes the strangulated obstruction. What happens is abdominal pain disproportionate to physical exam, suggest with the intestinal ischemia. So if it is strangulated, like having looped around each other, what will happen? The blood supply will be disturbed. So having intestinal ischemia. So you have to know. I will show you how you can differentiate from small bowel obstruction from ischemia when we'll go to ischemia topic. Then comes tachycardia, tenderness, fever, marked leukocytosis, and lactic acidosis. So these, I was about to read it from there, but here it is already written. So if a pain out of proportion presents with fever, leukocytosis, or any lactic acidosis, sometimes they do tell you about lactic acidosis, sometimes they don't. So you have to know if a female or male is presenting with out of proportion pain. If she is presenting with the pain and not passing any flatus, this is small bowel obstruction. Now you have to rule out why is it not intestinal ischemia? So intestinal ischemia, the pain is so out of proportion that you doesn't even feel like, okay, this might be a small bowel obstruction, but this pain is too much. The way she's shouting, the way she's crying, it is like too much, right? So you have to know this pain is basically not small bowel obstruction now. Now it becomes intestinal ischemia. So you have to see the presentation where she's coming. On the basis of that, you can see it is acute or is it chronic. And then you have to differentiate from acute small bowel obstruction from the intestinal ischemia. So on the basis of that, you can tell. Sometimes they do give you lactic acidosis, sometimes they don't. So you need to know if intestinal ischemia, it is going, the pain is out of proportion. They will definitely tell you that she is unbearable or she is not able to tolerate this pain. So they will give you a little bit of hints. So on the basis of that, you can tell this is small bowel obstruction and this is intestinal ischemia. Then approach. See, they are telling you here how you are going to approach the patient. Approach means how you are going to start the treatment. So what are you going to start with? You have to distinguish these 3 important goals. What are you going to do? So you have to distinguish if it's ileus or obstruction. I will tell you what is ileus and what is obstruction. So likely and easily reversible etiology of obstruction, and then differentiated complicated obstruction. Imaging, you are going to start with X-ray, CT scan with IV and others. So why are we going to start with X-ray, not with ultrasound? So we are going to start with X-ray because we have to see the air, right? In ultrasound, you are not going to see the air. In X-ray, what happens is if there is an obstruction, if there is any perforation, you will see air in the diaphragm, right? If you go, that's what I'm saying, go to, whenever you're reading this, make sure you see at least 1 or 2 X-rays of it, at least see CT scan of it, so you get to know how are you going to do it. So the first thing that comes, if a patient is presenting, you have to choose X-ray, abdominal X-ray, not go for ultrasound. A lot of people do misconcept about it. So you need to know where you're going to do ultrasound and where you're going to do X-ray. Triad of the dilated small bowel, air fluid on the upright films, and paucity of the air in the colon. Then comes CT. CT is basically discrete. Like you did X-ray, you didn't find anything. You didn't find any of this. Let's suppose something this happens. So you are going to do CT scan. You're going to see any transition point, any distal bowel decompression or intestinal contrast. So what are you going to do with it, right? So here, you are not going to do CT scan without contrast. You need to do CT scan with contrast. So it will be easily show you the loops of the small intestine. So in that basis, you can tell it is an intestinal ischemia, or it is basically a strangulation, or it is just a small bowel obstruction, because you can rule out small bowel obstruction just on the basis of X-ray. But if it's not showing up, now you have to rule out, is it small bowel obstruction? Is it ischemia? Is it paralytic ileus? What is going on here? So you are going to do with CT. When you write CT, it's not just the CT, because CT is not going to show anything, because CT shows all those like not soft tissues, right? So you have to do IV contrast. So on the basis of that, you can tell the soft tissues. Okay, so you need to know, if you are writing CT, you have to write down CT with IV contrast. Writing CT is not going to give you any marks. Okay, then comes the other, basically you can do upper GI-CT. This is very less common, so you can still remember that if it's very easy. Like you can do oral contrast and ultrasound and MRI. So here, ultrasound may consider, it is not the priority. People do misconcept that it's abdomen, so we're going to do ultrasound. This is wrong. Then comes laboratory. You have to do, obviously, you need to rule out the intestinal ischemia. So you have to do CBC, electrolytes, burn creatinine, lactate, creatinine and hematocrit to see the dehydration level, fluid and electrolyte abnormalities, any strangulation for the leukocytosis. Start. Okay. Now the female is presenting in emergency. If they ask me to write down 3 answers, what I'm going to start with, I will start with IV fluids. I will start with bowel rest. Okay. And I will start with NG tube. Okay. IV fluids, because the patient might be dehydrated. So I have to start with IV fluids, resuscitation. If there is one more option, you can add urine output too. But IV fluid is very important. So you cannot miss IV fluid. Then comes the NPO. NPO means, because I want NPO, basically I'm giving the bowel rest, right? So if you are going to, she's already having obstruction. So you have to start stopping it from adding it from the mouth as well, because if you're going to keep on causing obstruction and it's going to perforate, right? Then moving on to the next one, which is basically NG decompression. NG tube you pass, take out all the fluid or whatever thing, so would be easy for you. Never ever jump into laparotomy. Okay, laparotomy comes in like in the thing when you feel like, yeah, now this obstruction is going to happen, now perforation is going to happen, now no viable tissue, I have to save this patient no matter how. But still, in the small bowel obstruction, you start with NG tube. Okay, so NG tube used for the gastric decompression, all this nausea, distension, and the risk of aspiration from these things. So you, after doing all of this, you have to wait for 48 hours. And then if there is no improvement, then and complication develops, then you do surgery. Okay. If they give you a scenario where they already tell you, we have give IV fluids, NG tube is passed, NPO, and we waited 36 hours has been passed or 48 hours have been passed. Now she's still not recovering. So now you have to move on to the surgery. You cannot wait for like something else. For Crohn disease, you consider GI consultation right away with the steroid. Maybe the Crohn is flare up, so start with the steroid. If you read Crohn disease, it's written there nicely that how you are going to treat for the acute Crohn disease. If no clinical features of ischemia, like as I told you, only the conservative management. If there is ischemia, so you have to do with the laparotomy. Okay. And with the fluid resuscitation, NG tube, with the frequent, okay, with the frequent re-examination by the surgical team, and then duration and SPO fails to resolve or the symptoms of ischemia develop, then you are going to do the surgery. Okay. If the ischemia develops, the first thing I'm not going to do, I'm not going to do like NG tube. I'm going to start with that, because if I put NG tube with ischemia, the bowel is about to perforate, and I put the NG tube, basically I perforated it, right? So you are not going to play with it. There you are going to start with a laparotomy. So you need to see what they are giving you, what their presentation is. On the basis of that, the answer would be changed. Okay. If high risk of ischemia based on the clinical features, urgent surgery to prevent irreversible ischemia, early post-operative SBO. If the bowel obstruction does not return within 3 to 5 days after surgery, what are you going to do? Extended conservative therapy. So you have to do the bowel rest. Bowel rest is basically like doing NPO. And then fluids, TPN is appropriate. If necessary, so if presence of the ischemia or the perforated demonstrated surgery, then comes the prognosis, then prevention. Upon like surgery, you can save it like four times. Now comes the paralytic ileus. One of the very common presentation of the paralytic ileus is any surgery that happened, like they will tell you in a scenario that a surgery happened and now she cannot pass any fluid. A surgery happened and now her abdomen is distended. A surgery happened like cholecystectomy, anything. They will give you a scenario. If they want to give you, write down the paralytic ileus, they will write down any perforation, or they will tell you that she was taking opioids or she was taking anesthetics. Like anesthetics obviously comes with the surgery. So she had been like having this some kind of sort of any surgery. Mostly they give you surgery, but they can give you infection, inflammation, electrolyte imbalance. Mostly potassium causes it. So they might have a problem with the potassium, maybe having a DKA problem when she was using a lot of insulin. Now the potassium is disturbed. Now she can present with a paralytic ileus. So you need to know all those causes where the potassium level is disturbed. So along with the potassium level, paralytic ileus is present. So you need to know how the potassium level is disturbed. So she might can present with a DKA. He might can present with HHS, right? So in all those features where the potassium is disturbed, it can present at the paralytic ileus. So they are not asking you to do all the way and write on DKA. They are going to ask you the paralytic ileus because they're giving you the presentation of paralytic ileus. I'm just giving you a little overview that the potassium might be disturbed in any of those causes and it can link with the paralytic ileus. So you need to know this. Often seen for the patient in post-operative setting from the intra-abdominal abscesses, then pathophysiology is like any of these of substances anyway. Not same as the intestinal pseudo-obstruction. So you need to know Ogilvie, like intestinal pseudo-obstruction and paralytic ileus. I think I'm saying it wrong, but the word is like something Ogilvie. So we will read about that as well. So paralytic ileus, you have to distinguish from it because that is the large bowel obstruction, but this is like small bowel obstruction, but this is not a true obstruction. This is a false obstruction or pseudo obstruction that happened because of that particular disease or particular treatment, and now the particular treatment will resolve, so this treatment will dissolve as well. But in the small bowel obstruction, the actual small bowel obstruction, there is actually an obstruction present because of adhesions, hernia, strangulation, or something like that. But here there is an underlying pathology, any electrolyte disturb, any surgery happened, any medication. Once that is resolved, this paralytic ileus will resolve as well. So you need to know, they will give you a little bit of hint where you get to know, yeah, this is small bowel obstruction, this is paralytic. Over there, they will give you a surgery of particularly of the intestines. They will not tell you that surgery of cholecystectomy happened, right? So they will give you a surgery of paralytic, which happened like of small obstruction, which happened like 5 years ago, and now she is having obstruction. So you don't have to miss because of the surgery it can present this or this. So you need to know what kind of surgeries can present with the paralytic ileus and what kind of surgery can present with the small bowel obstruction. Then you need to know clinical features. Bowel obstruction are diminished and absent. Pain is often diffuse and less frequent. So small bowel obstruction has more pain and this has less pain. And it is basically colicky pain. Passing gas is the most useful indicator. So in this, they might be passing gas. Okay. Over there was total obstipation, no stool and no gas. Post-operative, so as I told you, it might return into 24 to 48 hours. Investigation, you don't need to do any investigations because this is related to some surgery, so you don't need to do. That's what I'm saying. You need to know the diagnosis. On the basis of diagnosis, the investigations are going to change. So you need to know basically what the diagnosis is and how they are presenting it. Okay. If ileus persists and occurs within abdominal surgery, review patient medications, maybe taking opioids and all those electrolytes, so magnesium, calcium phosphate, creatinine, BUN, and LFTs. So you have to treat the underlying cause. The potassium treatment will help you. If having this initial treatment, what you can do is NPO, giving bowel rest and put the patient on the IV fluids, and then do NG decompression and causative treatment, like all those sepsis, medication, whatever the underlying treatment you have to do. So the same treatment is kind of same, doing NPO, fluid, and NG. Okay. Then comes the intestinal ischemia. I want to go it along with it, so it's kind of easy. Pain out of keeping with the patient findings. So patient is yelling, crying, shouting, going all the way. This is something which is not small bowel obstruction. Okay. Now intestinal ischemia and mesenteric ischemia. These two are kind of same, but kind of different as well. How they are different? This is basically intestine. All of the intestine having ischemia. They are not clearly saying this part ischemia. But mesenteric ischemia is basically the mesenteric artery. If we remember and go to anatomy, the mesenteric artery particularly having ischemia. So wherever it is supplying those splenic flexor or whatsoever, that particular point is having ischemia. So if they are telling you that the patient is having right upper quadrant pain, and she's shouting out of the way, and she is having this intestinal ischemia. So you need to know, you can write down mesenteric ischemia. She might can present you that particular point more preferably. So they are giving you a hint that this is mesenteric ischemia, not intestinal ischemia. If they give you a generalized pain, something like that, she's crying, shelling, blah, blah, blah. So you can tell, yeah, this is something like that. Okay. So here it is written. What are the common sites of superior mesenteric artery? Watershed, splenic plexus that I was talking about, left colon and sigmoid. So if she's specifically, or the patient, I'm not she, so the patient is specifically telling you this part is hurting. So you get to know, yeah, this is mesenteric ischemia. This is not intestinal ischemia. Okay. So this might come at acute and chronic. Chronic is basically she or me, he already have developed the tolerance to it. So it is kind of okay, but the chronic will present with the fear of eating. So they might have a weight loss. They feel like after eating food, they will have pain, right? So chronic, you need to know after eating, they will have pain. So they have fear of eating. That's why they're having weight loss. Okay. Then acute is basically with a pain out of proportion, vomiting, bloody diarrhea, blotting, and all those peritoneal signs, course, and the hypotension shock, because this is acute. Suddenly happened, having a lot of features. So investigation, you are going to start with the leukocytosis because it's a lot of leukocytosis, and then late finding is leuko. So you need to know this is late finding. Patient came to you, it started like 10 minutes or 1 hour ago. She's not going to give lactic acidosis, right? She's not going to present on the investigation that she's like having lactic acidosis. But it's not important that she can present you leukocytosis as well, because it might not be sepsis that already happened, right? Only ischemia is happening. So you need to know lactate, CK, LP. You have to observe the progress, hypercoagulability. What are you going to do is X-ray. Obviously, you have to rule out any perforation happened or not. So perforation, anywhere word perforation is used, what are you going to do is abdominal X-ray. CT scan, thickened, like then you can do contrast CT scan, as we have already discussed. What are we going to do? CT scan, and especially the contrast one. Then CT angiography is the gold standard. If they ask you how are you going to build up your diagnosis, CT angiography. But if they are going to ask you what is the first step you are going to do, then it's abdominal X-ray. Okay, so you need to know what they're asking and how you are going to write down the answer. Then abdominal pain and metabolic acidosis is bowel ischemia. Treatment is fluid resuscitation, metabolic acidosis, NPO, NG-tube, and prophylactic antibiotics, because here sepsis could be one of the cause, so you need to give. Then avoid vasoconstrictor. If you give vasoconstriction, already obstruction happened. Now you are doing constriction. You are putting the patient's life into something. It is like killing the patient. Okay, so you cannot give that. Laparotomy, to extend the viability. If you see that there is non-viable tissue and it is spreading, all you got to do is laparotomy. Then extent of the bowel viability is uncertain. Laparotomy 12 to 24 hours. Angiography, thrombectomy, these all things are done later on. And some general thoracic surgeon is going to do it, not just person in always remember your limits as an emergency doctor, your limits as a family doctor. Then comes the tumors of the small intestine. I mean, you can read these ones. It's not like all this CT scan is going to done. So there's not I have to give something about this. Short gut syndrome, I would say there is something that is important in short gut syndrome, and I couldn't find it here. Maybe it's written in gastroenterology. So read short gut syndrome from there. There is something that is very important. How much is the length and how much is the length cut down? So what is the problem happened? So you need to know those. Okay. So now moving on to the large bowel obstruction, if we have time, let's see. Okay. So let's do large bowel obstruction quickly. Large bowel obstruction. Okay. So let's do large bowel obstruction. Okay. So large bowel obstruction is basically here. This is the main common causes. What are the main common causes? Cancer, valvulus, and diverticulitis. So you can see the small one is different from the large one. So at least need to know these top 3 causes. Obviously, these can present, but this is top 3 causes. So adenocarcinoma and diverticulitis, valvulus adhesion, so all of these things. Then cecum and then tenderness. Don't forget common one just because of uncommon one. Okay. Clinical feature is open loop and closed loop. So closed loop is more common. So just because this is more common, don't forget this one. Do most common one, but don't forget the uncommon one as well. Investigation is CBC differentials, one electrolyte, creatinine. So you have to do everything. Maybe anything is causing that problem. Obviously, the treatment is going to be same as we already discussed, IV fluids and gastrointestinal decompression. And in this, you are not going to do decompression from NG tube because the large bowel obstruction is present below. So you have to do decompression from the lower side, either doing colonoscopy, either doing anal, like anal passing. Okay, so you have to see what are you writing in this one. Then valvulus is basically initial decompression with a flexible sigmoidoscopy, as I already told you, either colonoscopy, either sigmoidoscopy. So you're not going to pass from all the way to the mouth to large bowel obstruction. So you have to take the patient feel comfortable as well. You are treating it, but doesn't mean that you have to go all the way just like that way. Operative reduction, if it's sorry, causing problem. Then colorectal obstruction, ostomy alone, like fecal diversion, colectomy, and anastomosis, Hartmann syndrome, and this everything. So then prognosis, this is a very nice distribution about the SBO, LBO, and paralytic. So you can read this one, it will help you a lot. If you are going to start the topic, first go through this and then go and read small bowel obstruction, large bowel obstruction, and paralytic ileus. So it will help you to build up a different like a concept, and make sure whatever you are reading, open the Google and read, see the pictures of it. Then comes a functional large bowel obstruction like colonic pseudo obstruction, Ogilvie syndrome. Then Ogilvie syndrome is kind of same like a paralytic ileus, but here all the problem is happening in the large bowel obstruction. That was happening just functional. And this is kind of important. Don't just forget it because this is not important. So it is basically acute pseudo distension of the colon. Mechanism is unknown. So most common is trauma, infection, and cardiac, maybe MI, CHF, all of those causes. Then disability, drugs, anything, hypokalemia, as I already said, retroperitoneal. So anything could be the cause. So, and the basis of that, you are going to see the abdominal destruction, but distension. So having pain, but not all, like too much of the pain. So you need to know this might be like, this is functional one. So they might give you a scenario, scenario where they are going to differentially saying that this is having a trauma and now she's having this they have an infection, now she's having. So this is basically functional one. What are you going to do? X-ray. Make sure you know where you are doing ultrasound, and make sure you know where you're doing to X-ray. In family medicine, those kind of approach is different, but this is approach of general surgery. So you need to know you are going to do X-ray and what are you looking for. So on the basis of that, you can easily choose the answer. So then comes is basically treat underlying cause, NPO, NG tube, decompression, like GD. This is what I was talking about. You are not going to pass the NG tube. You are going to pass the rectal tube. Okay. And after passing the rectal tube, you are going to do decompression. Then do colonoscopy, neostigmine, if she is having or he is having something which is basically needs anti-drug. So you are going to give neostigmine. Then surgery is kind of rarely performed if she is having, because this is something, if that particular thing that was causing this this problem, now that thing is removed, so it will be very easy for that to get treated. So most resolves with the conservative management. So I will stop here because only 10 minutes are left, so we can see if you guys have any questions. And diverticulosis, diverticulitis, anal fissure, hemorrhoids, we will do finish this one tomorrow, and we will start next topic. And we can start any topic you guys want. Maybe we can start family medicine or emergency medicine, whichever you guys like. You can tell me. Okay, thank you.